Before COVID-19, patients experienced challenges in healthcare that could possibly be improved with telehealth. This is John. He has a chronic illness. He lives 3 hours from his treating hospital and dreads travelling to all his appointments. He finds waiting so hard, taking time away from work and his family. Added financial pressures hinder his experience of healthcare. We planned to co-design telehealth solutions with patients and clinicians that would help solve some of these problems. But then we found ourselves amid a global pandemic. Hospitals were closed, no one could visit, and outpatients were shut down. We needed an urgent response. We could not wait for perfection. We had to do what we could to support and enable telehealth solutions at pace. With our help, rapid access to telehealth transformed not only John's care, but the care of many patients in our hospital, enabling access to healthcare from work and from home. 150 staff and teams have been supported by us to deliver video-enabled care. Over 90,000 calls have been conducted virtually since COVID arrived over 12 months ago, representing 29% of all outpatient visits. This is in keeping with Sláinte Care actions, where telehealth will underpin new models of care, and the HSE's Safe Return to Health Services strategy. But how did we know this was working? How could we keep it growing? We chose to use action design research. In ADR, you set about understanding your problem in the real-world context, creating artefacts that can be shared nationally, evaluating them, reflecting on that, and then applying and sharing the learning as you go forward. We developed this model from the learning, and it helped to guide us to ensure success. It highlights the importance of governance and security, business analysis, expert provision of software and devices, nurturing adoption and process quality improvement, and we planned how we would spread and scale these changes throughout our organisation and nationally. Fundamental to all of that is keeping patient preferences as our primary focus. This model guided us in delivering 17 artefacts that will be shared nationally. To hear patient preferences, we sent out surveys and conducted interviews and focus groups. We have listened to the experiences and recommendations of over 130 patients. In running the focus groups, we developed a patient consent form, a patient information leaflet and a guide. This guide has been shared to allow others to get the most from their virtual focus groups and avoid the challenges we faced at the beginning. We adopted technology that had been adapted from its use in remote communication for the National Ambulance Service. It was important to link with our Chief Information Security Officer and Data Protection Officer, who approved the implementation of the platform. Our Chief Information Security Officer added additional bandwidth to our network in anticipation of the increased requirements. We developed guidelines for use of video consultation for hospital-wide use and a patient information leaflet that followed emerging recommendations. We spent a lot of time with clinicians understanding their workflow and how virtual care could be embedded. We believe this has been a critical success factor in creating and sustaining spread. It is fundamental that virtual care enables and supports the workflow and does not hinder it. We analysed over 50 services and how virtual care could support them. Use cases have been mapped, including an ideal workflow. The simplicity of giving devices can make the workflow easy and therefore adoption improves. Zoom licenses were issued quickly for class and group work. We found 2 screens allows for easier documentation into the EPR during a video consultation. Integrated webcams perform better and minimise loss and damage. Devices with SIM cards were loaned to patients so they were not excluded or left behind, and wireless headsets allowed for freedom of movement for clinicians. In order to support adoption, we created a stakeholder map to be clear on who we needed to inform and influence, knowing who our main supporters might be. A data control worksheet puts governance and standards on record keeping. A telehealth hub was a dedicated space so staff could optimise use of virtual health. Another critical success factor was providing electronic patient record for outpatients. This allowed staff to record documentation in real time and deliver care off-site even when forced to isolate due to COVID-19. We developed forms for 10 different services and incorporated the State Claims Agency requirements for documentation of virtual-enabled care. These forms populated electronic discharge summaries to allow transfer via health mail to GPs. This built on and enhanced the work we had done supporting workflows. This electronic form allows users to document the type of consultation, if it is a new or return visit, and information required by the State Claims Agency and best practice guidelines such as confirmation of ID, consent and explanation of benefits and limitations of virtual clinics and the presence of a third party. While we had early adopters, it was critical that we show this mode of care was available. We set about making all relevant staff aware of its benefits. We presented at hospital ground rounds, to the HSEP eHealth Advisory Group, and had a 4-page spread in the quarterly hospital magazine, promoting all services enhanced by virtual care. Demand for virtual care continues to grow, but remains a high challenge, high support area of growth. We have created a network of virtual health champions and formed a virtual health working group. As mentioned, we listened and engaged with patients and staff as we progressed, using virtual focus groups, interviews and survey questionnaires over 3 time points from June 2020 to April 2021. 12% of patients reported needing help with tech, increasing to 22% this year. This may suggest we are reaching patients who have lower levels of digital literacy or tech confidence, and efforts to include all are working. Patients are saving on average 2.5 hours travelling. Access to smart devices continues to rise, but we are not there yet. Patients gave 5 out of 5 stars for their virtual healthcare experience. Clinicians reported a 60-40 ratio of phone to video calls. 25% of calls included family or carer. 80% of clinicians were happy with the standard of care delivered virtually, and 87% would prefer a hybrid or blended model of care as an option into the future.
And I think most people during the COVID era were thankful not to have to come into the hospital. So it remains to be seen when the lockdown stops and the vaccination comes in, whether these patients will want to drift back into the hospital or not. So I think we're just a little unclear about what will happen in the future. I'm hoping that it never drops below 50 or 60%, but that remains to be seen. So that's a challenge, and I think obviously the National Broadband Plan will hopefully deliver, but it might take several years to do that.
We compared different platforms and all had pros and cons. An approved, secure platform that supports workflow, ensures good patient experience and outcomes, and is designed for scale and expansion is crucial. Technological, clinical and legal features should be considered, and clinician and patient user experience prioritised. A hospital telehealth maturity model developed by Manat in 2019 allows services to benchmark their progress and create a roadmap for development. Maturity will be sustained by a desire to create a digital health experience for patients, a fearlessness to disrupt the status quo, a willingness to push at the edges, an understanding of tech-savvy patients, challenging the notion that patients always need to be seen physically, letting community need and clinician usability, not return on investment, drive virtual health decisions, and seeing virtual health's possibilities as endless. John's future healthcare will be better as a result.